I'm just going to post it to the rest. Hold on.
Good afternoon and welcome to this weekly international COVID update from AIG. Every week we have a very eminent international specialist who comes talks to us about what's happening in their country. And this week we are extremely glad to have one of the pioneers in gastroenterology from Israel, Professor Dotan, coming to talk to us. Iris is the Director of Division of Gastroenterology at the Rabin Medical Center, Tel Aviv. And of course, she is not only the Director of Gastroenterology there, but she is the President of the Israeli Association of Gastroenterology. She is the President-elect of the IBD, and I think, of course, she has several other positions. More than that, the interactions we have had with her shown that not only how powerful she is in Israel, but also so many innovations and research papers that are associated with her. Iris, thank you very much for being with us. Moderating this session, we have also with us Professor Hilmi. Ida is a professor and head of gastroenterology division at University of Malaya. She looks very young to be actually the head, but she's very experienced, has a huge experience, especially in IBD, and has published a lot in this area. She'll be moderating along with Dr. Rupa Banerjee, who is the chief of our IBD Center here at AIG. Thank you very much for everybody, and Iris, thank you for being with us this morning, and we're all looking forward to hearing from you.
Thank you very much, Professor Reddy, Dr. Banerjee, and Professor Hilmi. It's a pleasure to be here with you. As always, the AIG is visionary in preparing those webinars, which I've learned a lot from, and it's a pleasure to broadcast to you live from the Rabin Medical Center in Petah Tikva, Israel. Can you see my screen?
Yeah.
All right.
Yeah.
Okay, great. If you can see my screen, then we can start. Okay, so actually the title that I've been asked to discuss is Overcoming COVID-19 in Israel, Approach and Innovations. And actually, when we are talking about this, we should first ask ourselves, are we really overcoming COVID-19? And as you can see in this slide showing us the death rate for 100,000 people, you can see that in some areas we are more overcoming COVID-19. And if you can see my mouse, you can see that in some areas it is low, as the arrow points. And in some areas in classical Europe and in the United States, we are still not completely overcoming this dreadful disease. And the situation in India, if we would have looked, so of course the number of the death compared to the size of the population, at least the reports, are very low. So we have been fortunate in that. And actually, the numbers are important, but what is very important is not to overwhelm the healthcare system capacity, which luckily did not happen in Israel. And I'd like to share with you some of the insights that we think resulted this important outcome. So what is the important, if we still didn't overcome COVID-19 globally everywhere, so what is the importance of addressing preliminary lessons right now? So actually, as we have seen, the curves are flattening in some areas in the world, but not in all of them. In some of them, they're still on the rise. So we need to be very careful about that and to discuss online what is going on. Second, we all fear this second wave that probably will happen before vaccination is available. So we need to take rapid lessons from what is going on now. Another interesting insight that I'm sure we all thought of in the last few months is that actually the 21st century threat, one of the major ones, if not the most important, is pandemics. We were all thinking throughout the years about antibiotic-resistant bacteria, but we see how dreadful the virus pandemics might be. And interestingly, SARS-CoV-like viruses, so this specific epidemic, might re-emerge. And actually, I was overwhelmed when I encountered a report from more than a decade ago after the original SARS epidemic. And this was from Hong Kong, and it was called Severe Acute Respiratory Syndrome Coronavirus as an agent of emerging and re-emerging infection. And actually, it was fascinating to read this, especially when you read it now in retrospect. And the authors of this paper conclude, and they say the presence of a large reservoir, I'm reading, of SARS-CoV-like viruses in horseshoe bats, together with the culture of eating exotic mammals in southern China, is a time bomb. And they said it in 2007. And they added the possibility of the re-emergence of SARS and other novel viruses from animals or laboratories, and therefore the need for preparedness should not be ignored. And actually, I think that since it was probably not addressed enough then, we shouldn't do the same mistake again, and we should be prepared for the future and learn our lessons fast. So what will be the agenda for my talk? I'll give you a few facts and some figures about what is, of course, going on in Israel generally, not only in gastroenterology. We will discuss a little bit what happens when you face actually an invisible enemy. So address information and intelligence, artificial intelligence in Israel and innovation, just the tip of it, because there's a lot, of course, as you may know. I'll give you the sample of the Rabin Medical Center in Petah Tikva, Israel, and the Division of Gastroenterology, the strategy and the approach that we had here addressing the threat of coronavirus. And since we're gastroenterologists and our field of expertise, specifically honoring also Dr. Banerjee, Professor Hilmi, talking about inflammatory bowel diseases, mentioning updates from the IBD Secure, and what we did here specifically at the IBD Center in our center. So COVID-19 in Israel. So here are some, I'll move this so that you can see my screen. So in Israel, we have over 16,000 confirmed cases of coronaviruses now. In the last few days, we don't have new patients. We have 279 deaths, which makes a low death toll relatively. So the fatality rate is 1.7%. So this is important to mention that the rates in Israel are considered very low. Now, some of this low rate is attributed to very strict health policy, both of the government and also of cooperation of the public. And I'd like to take you through some of the important dates that we had here in Israel. So first of all, the first COVID-19 case confirmed was in the end of February, actually, in Israel. So we started a bit late, and the first death was about a month later. But what we can see here, that we had a few restrictions. So at first we had home isolations for all arrivals, so a 2-week quarantine that was suggested at first. Then schools were closed. The parliament actually approved phone tracking program, which until that time was used only for security reasons. So to use that for civilians was a major issue in Israel, but it proved to be helpful. Israelis were not allowed to leave their houses, and actually we went in April into complete lockdown. And this was specifically meaningful in Israel. I'm sure that all over the world to have complete lockdown is important, but in Israel, April was, of course, the time of Passover, of Easter, the Ramadan. So Jews, Christians, and Muslims all had to stay at home during very important holidays, and especially in Israel later on, Independence Day and Memorial Day. So these were complete lockdowns. However, we're starting to see the light. I'm speaking to you now that we don't have a complete lockdown. The shops are opening, partially back to schools and going completely back to schools. And we even hope to open the bars, and people were allowed to go to the beaches, the beautiful beaches of Israel. So hopefully we are going to some, in the shadow of Corona now, it says, routine. So this is part of the reason for the achievements of Israel in controlling and in trying to overcome COVID-19. Other reasons, of course, might be related to the fact that Israel is not only a young nation like India, so both nations, India and Israel, are celebrating. We already celebrated 72 years, so we are a young nation, but we also have a young population. And here you can see the comparison between Israel and the age groups in Italy, for example, as an example of where the problem was significantly in higher magnitudes. And you can see that in Israel, the population is young to begin with, and the relative representation of cases was in this young population, which is considered to be of lower risk. So perhaps this is also related to the low death rate that we had here. I wanted to discuss a little bit how we addressed it in addition to having strict public policies and the cooperation of the public, which was very important. And Israel is known for being a startup nation, and from Startup Nation Central and from Independence Day projects, you can see, and you can Google it, 72 Israeli technologies fighting COVID-19 for the 72nd birthday of Israel. And you can see that if you subcategorize them, in almost every field that is important to addressing such a horrible pandemic, there is an Israeli startup and innovation that is suggesting some relief, whether it is remote health care and patient monitoring, diagnostic, testing, screening and support, treatment attempts, and I'm sure you've heard of some of them, protection and prevention, how we can protect ourselves, critical care technologies, how we can have respirators, what can we do with the patients, and of course, important things, mental health and general well-being, tracking tech and mobility services. All of them you can find when you look at these 72 startups, which I highly recommend. I enjoyed looking at them. They are all science fiction. Israel is also known for being able to use fast its artificial intelligence and databases that exist. And actually, this was an interesting experiment that is already published, and it was using a framework for identifying regional outbreak of COVID-19 from 1 minute, so to say, population-wide surveys. So we all received a survey that took only a few seconds to answer, and based on that, and based on alerts learned from previous virus outbreaks, so the designers of this artificial intelligence-based technology were able to tell you which is the next neighborhood where you would expect to have an outbreak of COVID-19 in this case. And actually, this even helped the government to decide which neighborhoods should be more under lockdown, yes or no. Our medical center, the Rabin Medical Center, is actually one of the flagship hospitals of Clalit Health Services, which is the largest HMO in Israel and one of the largest globally. And actually, it was good to see that this major health maintenance organization was able to use its electronic medical records and its huge databases and artificial intelligence in order to help the patients and the people insured in Israel in general. And this is with the courtesy of Professor Ran Balicer, who had the Clalit Research Institute, and they were able to take the data that exists not specifically only on COVID-19 people, but to identify based on previous data from influenza outbreaks, who has high risk to have more severe disease when they will have it. And actually, you can look here at the points and see that some of these points are quite trivial. If you have a cardiac or vascular disease, diabetes, high blood pressure, and so on and so forth. But if you collect some of these points, you might demonstrate who, even if this person is younger, for instance, people who are younger than 49 years old, okay, if they have, for instance, 4 points plus, they will be high risk. Doesn't matter that they have a young age. People who are 70 years and over, of course, have a high risk. But if they have several points, and you can look at this and see how many points you need, they have an extreme risk. So these people, for instance, might be suggested to self-isolate, and they can be watched more closely. So this is one way to use information when you actually have no personal information on the people at that point. And here you can see development of this model where you can cut the highest risk of the patients with very good areas under the curve for prediction who will have the highest risk. And when you use this model, you might, of course, have prevention. So you might notify patients, and patients were notified and their doctors were calling them. You might prioritize COVID-19 testing for these people. And of course, once a patient is positive, you might decide based on his or her risk stratification if this patient should be taken care of at home or should they be hospitalized, and so on and so forth. In addition to artificial intelligence and to the electronic medical record-based use of the databases, of course, we have other technologies. So I know that you heard already on the Taito Care remote that actually has been used and again, it has been used in Telehealth services even before this pandemic to enable people, parents, to enable people at home using this small technology that you can hold in the palm of your hand, and you can use it to connect with your doctor and to show him or her what is your heart rate, how do your lungs sound, how does your throat look, and you can have some digital and telemedicine that is based on your own data. So of course, this was used a lot now when social distancing, but also patient and doctor distancing needed to be practiced. To show you how these and other technologies were used, of course, we are taking advantage of being part of the Rabin Medical Center. And actually what we needed to do here is to do rapid modifications to address an evolving threat where you have no data. And I'm sure you will share that feeling with me that you have no data and you had to do things to change things fast. So here you see the Rabin Medical Center is actually built from two major hospitals. So one is the Bellinson campus, where I'm broadcasting to you from now, which is the Tertiary Referral Center, the Transplantation Center of Israel, and so on and so forth. And we have a more neighborhood related hospital that is 10 minutes away from here, which is called the Sharon Hospital. And you see here Dr. Dror Dicker, who actually headed the corona efforts in this hospital, which turned within a few days into a corona-only hospital. So this was the first and only corona-only hospital in Israel, dedicated only for patients with COVID, which had a lot of logistic, and maybe we'll discuss it later, a lot of logistic rationale behind it. And actually, and here I don't want to endanger the Zoom connection with showing the YouTube, but you can look at it in the Rabin Medical Center site later on, and you can see how within a few days, actually, a new hospital was built and adjusted specifically and only for patients with suspected or, of course, confirmed COVID-19. What did we do here in the Division of Gastroenterology? So we have a Division of Gastroenterology that is also part in Hasharon Hospital and part in our hospital. But we needed to be aware of the fact that we cannot afford our division to go into quarantine, of course, and to have to self-isolate at home for 14 days. So we had to be extremely protected, but this was not enough, of course, and we divided ourselves into 4 capsules. So 2 in this hospital and 2 in the other hospital, maintaining a complete distancing between those capsules, so that if one of the team would have been infected or would have been suspected, not all of us would have to go home, and by this preventing service from a huge area in central Israel. And luckily, this proved to work very efficiently until now. Of course, we kept team protection, and I saw that in your previous seminars you discussed a lot team protection, so I will not go into this. We postponed our ambulatory care, but the urgent care was ongoing, and even the semi-urgent care, as we saw that this was going to be a long issue, the semi-urgent care was done as well. Of course, this is hard, and like we are maintaining now human control using Zoom, so we used Teams for discussions in our group. We used telemedicine and telehealth to treat our patients. Of course, I used a few live updates to the staff. It's very hard not to see the people that you work with every day. So we were trying to update not only by email, but also by short video films that were sent to the staff. And of course, we have the Clalit and Rabin Medical Center site to be updated on a daily and sometimes twice daily basis as required. As we said, we're all gastroenterologists and actually very focused on inflammatory bowel diseases, which were suspected to be important diseases where you have a pandemic, because some of our patients are suspected to be more predisposed to infections and especially viral infections. And actually, we could have been relieved by looking, and you see here the map of the world that was shown looking at, you see here Israel, the very tiny place here. This is Israel, and I'm not even comparing to what we see when we look at India, but this is very interesting, and we'll discuss those countries in a second. So published recently by Erica Brenner and colleagues and the Secure IBD, we see that at the moment from all over the world, we have 1,170 patients reported with a few hospitalizations and fewer deaths, actually, which is sort of a relief. I'm saying sort of a relief because when you look at the reporting rate, so you see that from Israel, we have report on only 16 cases, but even fewer cases reported from India with its over 1 billion inhabitants. So to tell you that probably in both areas, in Israel, in India, in China, where they had only 1 patient reported, so obviously there is underreporting. However, it was a relief to see that these patients were not overwhelmingly administered, and also that their medications, except for steroids, were not causing more COVID-19 severe disease to these patients. When you treat patients with inflammatory bowel diseases, you treat patients with infusions. A lot of them go to infusion center. Our infusion center actually takes care of thousands of infusions per year. And within a few days, because it was used to be in Hasharon Hospital, we had to move our infusion center. So this is part of the logistics that you have to handle within a few days. So we moved it to this campus, and within a few days, I'm very proud of our IBD Center that was successful in doing this and providing infusions to all of our patients. And this was actually part of the reasons that we discussed in the IOIBD. We had extensive discussion of what should you do with the infusions and with infusion centers, with your patients, with the staff, with the clinic. How do you do these infusions in these complex days? And actually, we see that we have already the guidance. You can see it in the IOIBD site, and you can see that we have guidance relating to patients, personnel, clinic operations, and general. I'll show you the poster in a second, but you can see it on the IOIBD site. But actually, you can see that all over the world, you see that the expert had to adjust and to do many steps in order to address patients with inflammatory bowel diseases that are treated with infusions, to increase spacing between infusion chairs, to increase the cleaning. So you have to address different things that are not only high medicine, but are very important to your patients, to reduce the number of patients. And some of us even considered changing the treatments that they give, reducing the duration, for instance, of infliximab infusions for patients. Some went to as low as 30 minutes per infusion for infliximab, to reduce post-infusion monitoring for those who were doing this, and so on and so forth. So you can see this extensive poster with specific recommendation by the IOIBD, and you can see it in the IOIBD site, and this was submitted and hopefully will also be published online as a manuscript. So in summary, we went fast from the level of the country to the level of the patient and the infusion center, but I think that the lessons that we learn when we are trying to address overcoming COVID-19 in Israel is that this is of course an unprecedented pandemic globally. None of us had seen this in our lifetimes. Hopefully we will not. Israel achievements can be attributed to the strict social and country, actually, we closed our borders, distancing policies, to public cooperation, which was overwhelming, to the effective use of information, artificial intelligence, and innovation, and the importance of the health maintenance organizations in Israel, and that all of us actually have electronic medical records that can be used for our benefit. The rapid modification of healthcare, and I gave, of course, the Rabin Medical Center in our own division scenario, but I'm sure that we can discuss your experiences. And I think that the most important lesson, and this is what you are doing at the AIG, that understanding that in order to overcome COVID-19 and potential future pandemics, we need worldwide efforts to learn from each other and to be prepared. And with this half optimistic and half cautionary note, I'd like to finish by thanking, first of all, the staff of the Division of Gastroenterology at the Rabin Medical Center, who had been overwhelming in their cooperation in treating patients and making sure that the staff is safe as well. Dror Dicker, the head of the Corona unit, Professor Yaron Niv from the Ministry of Health, Professor Balitzer from the Clalit Health Services, and Lihi Godni, our dietitian, for her insights and help in putting all of this together. And I'm showing you our 72nd birthday in Israel, where the staff of the Rabin Medical Center is thanking the Air Force. Usually we thank the Army. In this case, the Army came to thank us for our efforts in trying to address this pandemic. So thank you very much for your attention.
Thank you, Iris. This was indeed a wonderful talk, and I think it gives us ideas of what to do in all this COVID crisis across the globe. Secondly, it's very interesting to hear nice things now, that you have flattened the curve and that things are coming back to normal as we sit in lockdown, as we see number of cases rising in India, I think this is the best thing that can happen. Additionally, I just thought, when we talk of Israel and innovations, it is actually fantastic. I was just seeing that for a simple thing like a face mask, what Israel has done. And I just got in a few slides for everyone to see that there are apparently multiple, more than 10 innovations on face masks that they have done. And can I have the slides, please? Can I have the slides? Yeah. So the first slide that you see here is a self-disinfecting reusable mask. So you can just plug your mask at the end of the day, and the temperatures rise to 60 to 70 degrees. And then it is disinfected. So the next day you can wear it. What an innovation. This is one which I thought was particularly striking. And then this is the self-sanitizing fabric. Metal oxides like zinc, copper, nanoparticles are integrated into the fabric. So what happens as a result is that itself is virucidal, fungicidal, as well as bactericidal. So these are the innovations that are happening. And the most interesting was what was shown in BBC a couple of days ago, that this is a remote controlled mask for eating. So as soon as the metal reaches the mouth, the lever opens, you can eat without opening your mask. And I think even India, we are not far behind. If you see, look at our innovation. Now, we know that when we wear a mask, we often find it difficult to identify who is. So in this innovation in India, from a very small group in Kerala, they take pictures, and then the mask is built within 15 minutes. You wear it and you look just like you were before COVID and the mask. So I think these are all new innovations which are coming in to lighten our mood a little bit. We have a lot of questions coming in, and I'm going to hand over to Ida to ask relevant questions, because we have Iris and of course Ida. Both of you are stalwarts and have done wonderful work, and I'm sure that we'll have an interesting session.
Okay, thank you so much, Rupa. Thank you again, Iris, for that wonderful talk. It's always all your talks, like all your talks are. Okay, there are many questions that, and I actually have quite a few of my own, but never mind. We'll ask from the audience first. So Dr. Ranga Rao was asking about the question that is on everyone's mind, which is on a vaccine. So the question is, Israeli scientists are developing monoclonal vaccine in COVID. When will this become a clinical reality? Iris, do you know anything about that?
So actually in that we of course learn from the media like you, but there are there's more than one site in Israel, both in the north and in central Israel, very famous research institutes that are looking into treatments. One of them was reported to be related more to the vaccine, and one of them to the antibody. I don't have, I don't think anyone has a realistic clue, because of course, as happy as we are to hear that this is coming, and I'm sure that we'll be happy if it will come from Israel, we all know, and we are all in the issue of clinical trials, and we know that it will take some time until we can give it safely to patients. But yes, the innovations come from Israel and more than one site, and we were very happy to hear about that.
Okay, but still we won't know, I suppose. What do you guess would be the time? Most people would say 12 to 18 months.
Yeah, I guess that's the time, which is extremely fast. From innovation to a vaccine, this is extremely fast, and I'm sure that all the regulators will, relax their requirements in order for us to have some vaccine soon before a second outbreak or the next outbreak comes.
I'm going to interject with a question of my own. So do you do a mass serology testing in Israel, and would you consider that in a way protective and therefore your immunity card, if you like? Would you? What are your thoughts on this?
So there was a lot of debate actually in Israel about tests in general and about serologic testing. And actually, this is we have a lot. The ratio of tests per population is high in Israel. That's true, but we don't have mass serologic testing for Israel to show who already had the disease and is not going to acquire it. If this is true, you know, we always have the reports of patients that had a disease and now have another attack. We're not sure what the reason for that is, but we don't do mass serologic screening for the whole population, no.
And there's no plan to do that, because I think that was a big, some countries.
Yeah, that was a big debate, but not at the moment.
So Dr. Sura was asking, why is the mortality so low in Israel? 1.7%. It said, is it related to compulsory military training, which keeps people fit? I do have to have a disclaimer that we don't have compulsory military training, and our mortality is also 1.5%. So what would you reckon? Is it what you
So
said?
I would like to think that our compulsory military service keeps us fit. That's I think that the more reasonable explanation is, first of all, that Israel is a very young nation, as I pointed out. So when you have the population is so young, and actually we've seen that once the outbreak went into nursery homes and old people's homes, so this was a big issue. So when you have old population, this is a problem, and of course they are high risk just by their age and comorbidities. So this is one, and I think, and I don't know that this is related to the compulsory military service, but I think that the whole nation saw this as being a war, which it was, and then was very cooperative and very collaborative. And when we were told to stay at home at very important holidays, we stayed at home. So I'm sure that globally every Christian, every Muslim, and every Jew will know what it means not to be able to go out in some of your most important holidays, but still people did not go out. So I think it's public obedience and collaboration, as well as the population being quite young. I think these are the most important reasons.
Yeah,
I think, Ida, I mean, as they said, military training, I suppose here we have yoga and Ayurveda and things like that. I don't know what is working, but we also see lesser death rates than what what France or Italy, or as a matter of fact US now is kind of showing. What do you think is happening in Malaysia, Ida? I mean,
I'm inclined to think it's just like in Professor Dotan's case in Israel, the fact that they're relatively young, because in Europe it's probably an elderly population. I have an actually very interesting anecdote, if you like, where an occupational therapist in our hospital had some exposure outside. I don't know if you heard about from Malaysia, the biggest came from a mosque gathering, a tabligh gathering of about 14,000 people. So it just took a few, and then there was a mass outbreak. But what happened was that this occupational therapist actually then infected 13. She worked in the geriatric unit, the care of the elderly, and infected quite a few, and 6 of them died. So actually, I think if it was an elderly population, probably like Europe, we probably would see the same sort of death.
Yeah, I think in India also it's the same thing. What we are seeing, that the migrant laborers, where social distancing is a problem, and that is one group which is perhaps causing the recent spike in cases.
In Malaysia as well, definitely. Singapore, that of course is another big issue. So with the lockdown, the general population has been, the numbers have been controlled, but unfortunately, like in a lot of societies, the marginalized, the immigrant population, the illegals, some of them stay 20 people in a room.
We had a lot of public discussion in Israel about that point that you raised, Ida and Rupa, and also in Israel, some of the more religious congregations that have crowding in small apartments, and actually had the problems with keeping at first social distancing, and there we had the outbreaks then until everyone noticed that this should be taken into account and addressed. And actually, the point that you raised, Ida, is very important about the anecdote about the worker that infected. And I think that there was a lot of discussion about this relating to IBD and having home infusions and having people go to people's home. And I heard several anecdotes about concerns of the caregivers. Here we don't have home infusions, but concerns about the caregivers that they will infect those people who may be more susceptible by going from one home to the other, and one healthcare worker can expose many, many patients to the danger of this.
Absolutely. Yeah. It's just not that simple, isn't it, when you think of all the complexity. Okay, Dr. Patel asked about BCG. I don't know if do you have routine BCG, Professor Dotan?
So no, actually, in Israel we used to have BCG. So, but in the last years, maybe Rupa can answer that, because we don't have mandatory BCG in Israel for years now.
So interestingly, actually, the whole BCG story started because of some epidemiologic study and analysis again, that countries which had given BCG to their general population, the numbers were low, and then perhaps therefore BCG is the protecting factor. Now the issue here is that, you know, since this is a new disease, even as doctors, even as epidemiologists, scientists, everybody is learning. So right now, any common factor they find, it is being highlighted. I don't think we are still in a position to suggest that BCG is the vaccine which will protect against corona. I think that's, we are still not there, but then it all started from that one publication which came. So
to this point, Rupa, actually, your comment is very important, because I think that we are bombarded with so much information. Yes. Not only, of course, Google, but there are more than what I looked for this presentation, more than 11,000 publications in the last few months on COVID. So, of course, there is no one person that can read all those. Luckily, only about 50 of them were related specifically to gastroenterology. But it is a huge amount of information, which I think is part of the reason that many of us feel exhausted and overwhelmed, even without seeing one patient, because you have to learn so much about something that you know nothing about, right? And every comment that is made, BCG or not, at that point in time is just an association, and we will have to look further into that with a lot of research in the future.
So far, I guess nothing is still that magic bullet, right? Which is a shame, at least from what I've read so far. I think one of the questions that have been brought up as well is about whether isolated GI symptoms, or just GI symptoms alone, is that prevalent in Malaysia or Israel? I can't say about Malaysia, I have to say. I don't think there's any publication on that, but maybe Iris can answer.
So actually, at first we were very concerned, for not so much because of the symptoms, but because of the reports, of course, that the virus can be found in the feces and actually in the epithelial cells themselves, and that was a lot of concern. This was one of the reasons, by the way, that we took in our own division. So we took full protection for gastroscopies, colonoscopies, and everything, not only aerosol producing endoscopies. However, I think that as time goes by, while there are intestinal symptoms, and like we said a moment ago, so we can't make generalizations, we're not sure. However, in contrast to the first reports, that there are, in some instances, 10–17% of patients that will have different GI complaints, from anorexia to diarrhea, abdominal pain, and liver function abnormalities. The percentages are going actually down and are, at the moment, I think, concerned as of less important.
Yeah, I mean, I agree. I mean, and I think that brings me to another question, actually, of my own. I've often wondered, let's say I mean, for upper GI endoscopy procedures, EUS, ERCP, OGDs, we have full PPEs. We've also decided to do this, N95, face shields, shoe cover, head cover. I'm sure we're all familiar with it. I mean, is there any evidence that just your standard surgical mask and shield, for example, that you could still contract COVID? Do we have any any data of an endoscopist actually contracting COVID-19 from their procedures? Do you know of anything like
So
that? This is
actually,
also speculation, isn't it?
well, first of all, I wouldn't dare changing, because I think that one important
course,
point is
agreed.
that the staff, that the staff needs to be safe. Like safe staff, of course, is a requirement. Period. There is no discounts on that. And I'm not in Israel. I'm not aware of any endoscopies that attracted the COVID-19, whether protected this way or the other. So it's a relief for us.
I guess the reason why I asked this is because as of now, everyone has got, I mean, because I think COVID is going to be with us for maybe 1 year, 2 years, they speculate. And I guess it does bring me to the question of, this is something we haven't answered ourselves. Are we going to wear full PPEs for every case for the next 2 years? What are the implications? What do you think your idea is on this, Iris? Yeah.
So we are going to, until more solid information is going to come, and I don't see it at the moment coming, we are going to be fully covered. I think that this is very important. I think that this is one important mission for all of us as healthcare givers, and in our division for sure, that no one gets infected, that no one infects a patient, okay? So this is very important. You can't tell as long as people are not mass screened, like we discussed a moment ago. So we have no clue who is infected and who is not, and we are treating patients like that. I'll go to your point, I'll take it further. First of all, I hope that we don't have to do that for 2 years. It is somewhat annoying, but I think, and this is, we all try to see some positive aspects of this, of our change of habits. And I think that usually we need, and we usually, dismiss being protected, right? We go and do endoscopies and not fully covered and so on. So I don't know that we need to be fully covered with, fluid rejecting materials, but we do need to put masks. We do need to protect our eyes, right? We do need to be more careful. And all of us has been a little bit,
I do agree.
neglecting this.
Totally agree.
I do agree.
I have to say, when I started putting on masks regularly, I was thinking, actually, I should have been doing this, all the time.
I think you mentioning 1 or 2 years really, increased my heartbeat a little bit, because I'm still now gearing till end of the year maybe. But I think, are we going to go to a new normal? I mean, a little futuristic question, Iris, but do you think that the future will change altogether? I mean, the way...
Okay. Well, you asked me, Rupa, because Israel is the land of the prophets. So you know that we also say that prophecy is for the fools and for the children. So I'm unfortunately not one, and gladly I'm not the other. But I cannot tell you. Of course, I think that we will change significantly. Many things will change in our hearts. I think that all of us long for human touch, to be traveling again, to be seeing each other. We had to be at the AIG, right, celebrating 25 years of fascinating gastroenterology, right? So we miss that part. We miss learning from each other face to face and not by Zoom. And of course, I am sure that the world has many more aspects than our little worlds. So I think some things will change majorly, for sure. Which one they are, how long they will last. Maybe in 6 months, we're all the same as we were. Who knows? I will not make any predictions about that. I'll wait for 6 months and then we'll discuss.
What do you think, Ida? You just mentioned 1 year and 2 years.
Yeah, you'll be
nice.
Because of the 2-year comments that we started this discussion.
Yeah, I suppose because until the vaccine comes, it's a very infectious virus. I mean, I have to say that I was also a little bit skeptical about how infectious it was until we had that cluster. When you think one person can infect 13 people, I mean, that is, we talk about R0 and whatnot. I mean, this is like really quite real. And I almost feel like until there's a vaccine available and you have almost herd-like immunity, which is going to take a long time, then it may be with us longer and I think it will at least change the way, as you said, the new normal for a very long time. Hopefully until the vaccine comes. I hope the vaccine will come soon.
So may I ask? May I ask you, sorry for interrupting, Rupa and Ida. So can you tell me how are you doing your ambulatory care services now in your medical centers? For instance, for patients with inflammatory bowel diseases, what is the situation there?
So I think we've definitely, emergencies carried on as usual, but even that was quite tricky for a while because the hospital almost shut down emergency department for a long time, which I was not really very happy with, but I think there was a lot of fear, but that's coming back. And I've opened up the semi-emergencies for the EUSFNAs and suspected cancers and so on. I'm not so keen to open up elective fully yet for the reason of social distancing. And just like what you've done, Iris, for your unit, we've also got, we didn't call them capsules, but we've also split up our teams. So we want to keep doing that, as you said, because we don't want to completely shut down our services. So I think for the way I see it, for the next 6 months, I'm just saying 6 months for now, I think we're going to go easy on our cases. That would be
I think in AIG, what we have done is we are encouraging a lot of online consults. So what we are encouraging, particularly all IBD patients, just talk to us online. And if we suggest that you need to visit a hospital, we've got an artificial intelligence induced nice writing pad. So whatever I write reaches simultaneously as a printout to the patient. So what I'm doing is, so when I'm seeing the patient, and I think if I feel that this patient needs to visit the hospital, so I write over there that this patient requires hospital visit. So the local police and authorities have been informed. So if they see that, that is taken as a pass for the patients and it is easier for them to come within the lockdown. Other than that, of course, emergency, there is no other way. But even IBD patients with fever, all IBD patients, even if there is an obvious abscess, goes to an isolation ward, is screened and checked for COVID before being shifted down to a regular ward. So we have a separate floor altogether where all suspected or possible or plausible cases are. And I think that gives us protection. Our OPD services are open. We are seeing patients. Numbers are less because, travel is a problem. And we are screening to see that the most genuine patients actually reach the hospital.
Yeah.
The rest is being done online. I think so far this seems to be working good.
I mean, I think, so again, so maybe we focus in a little bit more on inflammatory bowel disease because that's all our subspecialty areas. I think from our perspective, I found that although I've carried on most of the treatment in the same way, there are some implications. So for example, the surgeries, my refractory cases, so they're elective surgeries, they're colectomies, that's not happening. So it does put us in a rather difficult position because funding is a big issue. They can't afford their biologics. For a while, the clinical trials had stopped as well. So that was another problem for me. So it definitely had impact, And Iris and Rupa, for example, I've got these very malnourished patients. They've got, I've got a young girl who's 24 kilograms, for example. And then I end up not knowing what to do with these cases other than exclusive enteral nutrition because I'm scared to give her steroids, I'm scared to give her biologics, and they are not going to operate on her. So I think, although I by and large, I agree, it's comforting.
I think the message for everyone here will be that so far from the secure IBD data, what we are seeing and analysis is suggesting that biologics in actual have not increased the risk of COVID. In fact, there is a tendency towards some benefit. So these are again, things and data which keeps on changing. But I think biologics and infusion for everybody can just continue as is. I think we have a lot of questions coming, but one question I have to ask both of you, and that is there are multiple questions coming on hydroxychloroquine. So that is freely available, I suppose, in this part of the world. And should they take it? And this question is, of course, I suppose this is going to be the last question, and I want an answer from both Iris and Ida.
No point asking me. I don't know.
No, I will answer. I will answer. Of course, this should not be addressed to us. Other people more famous than us addressed using hydroxychloroquine. I don't think there is any evidence to suggest that you should use hydroxychloroquine in definitely non-identified cases. And there are multiple attempts to use it for patients who are already infected, not always with good results, with positive results. So we have to look at the evidence. In that case, can't be speculations. We have to look at the evidence. And of course, we're not treating any of our patients here, the non-infected patients, as prevention, or we don't give any one of them hydroxychloroquine. And I think in medications, we should stick to the evidence.
So what do you give them, Iris? Anything at all? What about all the data on remdesivir, tocilizumab?
No, so this is being assessed in Israel, and I don't give them anything. This is the nice thing. And when you talked about closing your emergency room, we had a separate hospital for patients with COVID-19, with the suspected and with the confirmed, and they were treated there. So we didn't have to close anything of the emergency services here. And as part of that, we didn't treat ourselves any of the COVID-19 positive patients. It's just the things that we know from the medical literature. But this is why I say, so of course, all these treatments are being assessed as part of studies, and the right protocol, which we learned that is very complex for the patients that have severe disease, is very complex. So this should be learned and tested as we always do, as evidence-based. Here, you can't relax anything.
Agree. I think it's the same for us as well.
Yeah, I think so. As you see, and as we've learned today, Israel and its innovations, and that they've managed to flatten the curve, and that gives us hope that we should continue our process of social distancing, hand hygiene, and simple things like that. And I'm sure that we will also be able to overcome that. And with that, I must thank sincerely Iris and Ida, both of whom are very good friends, and they've taken their precious time out at different times of the day and been available for this webinar. Thank you once again. Thank you, Iris. Thank you.
Thank you very much, Rupa, Ida.
Thank you.
Bye.
Bye.
Bye. Thank you very much. Bye-bye.
Thank you, Dr. Reddy, as well. Bye.